Okay, so hello, fellow brain cells, and today in This Week in Neuroscience, we are checking out a study called Vagus Nerve Stimulation Therapy for Treatment-Resistant PTSD. So, let's see. As I assume you know, post-traumatic symptoms dissipate over time in the majority of these individuals. However, for a significant minority, the symptoms remain, and a PTSD diagnosis can be made after symptoms last for at least 1 month. And some individuals with PTSD respond well to cognitive behavioral therapies, which are like the absolute gold standard of therapy, at least from what I have been taught in university, or pharmacological interventions, but many others fail to adequately respond, are unable to comply with therapy, or experience intolerable side effects, or just relapse, which is absolutely heartbreaking. It is very sad. I have personal experience, sadly, with PTSD, and it's it really um lowers your quality of life, and it limits what you can do. It feels like a disability, because you become unable to do some things or go to some places, and you constantly feel like you fear for your life. It's terrible. It's terrible stuff. um and I'm sure you understand completely if you have had some kind of trauma where the symptoms persisted. Okay, so these authors have developed a combin combined approach that basically combines prolonged exposure therapy. As we know, for phobias, exposure therapy is the gold standard treatment, and it is very effective in treating phobias. And what they say, yes, they said here, they said it here, a gold standard cognitive behavioral therapy with short bursts of vagus nerve stimulation. And I I forgot. Oh my god, I forgot the function of the vagus nerve. I have to check it again. Longest in the body, containing both motor and sensory functions in afferent and efferent regards. And here, afferent and efferent mean from the body to the brain, and from the brain to the body. So upwards and downwards. This is what's meant. Um, the nerve travels widely throughout the body, affecting several organ systems and regions of the body, such as the tongue, pharynx, heart, and gastrointestinal system. So it's cranial nerve 10 out of the 12, and also there is speculated to be a 13th. Some people call it cranial nerve 13 or cranial nerve 0. Um, Let me just cranial nerve oh, no, 14. Oh gosh. Refers to the nervus terminalis or terminal nerve, is highly conserved multifaceted nerve found just above the olfactory bulbs in humans and most vertebrate, hope I'm pronouncing that right, species. Hmm. What what do something appeared when I typed nerve 14? What? Cranial nerve 14 was first identified. Yeah, that's the National Institute of Health. What? Nerves in the shadows. They are indeed in the shadows, because I've had brain and behavior, which was basically intro to neuroscience. We learned lots about the anatomy of the nervous system. That was the main topic of it all, and obviously we studied all of the cranial nerves as well. And mm, though we only mentioned this nervus terminalis, we were only mentioned, but we were told that it is often not regarded as a cranial as part of the cranial nerves at all, and so they're indeed in the shadow, and we were not even required to remember it for our test, for example. And now I see that there is even a 14th, which was identified in 1563. So I'm pretty sure that's around the time of the great geographical discoveries, where they, um, when they discovered uh, what is now America, the continent that is now America and Canada. Oh my god, not only America and Canada, North America, the continent of North America, and they also discovered a new way uh, of getting to India in order to purchase some spices. As far as I remember from my history lessons in school. So I remember something at least. Okay. Getting back. So, okay, let's see. The benefits extend to other related symptoms, including improvements in anxiety, hyperarousal, and asocial behavior, which I didn't know that asocial behavior was actually um, a symptom of PTSD, and I wonder what asocial behavior do some people exhibit as a result of PTSD. Hmm. Having antisocial peers in relation to PubMed. Okay. Psychopathy and antisocial personality disorder. What? Signal population with high rates of trauma exposure. It's unclear whether specific types of lifetime trauma are associated. Okay, so it's unclear. But here they are quite confident that it is associated. Antisocial behavior syndromes and additional psychiatric comorbidity, sorry. Um, okay, let me just try to do something. Where is my chat on Twitch? What is going on? I am still exploring how to do all of this. Oh my god, it's because I'm not logged in. Oh no. Okay, at least my chat hopefully will display here. Alright, so they developed, which is, this is like the marketing sort of slash selling sentence here. There was I was on this workshop for interpreting EEG data through MATLAB code, through specific MATLAB like library slash package, and there we were taught by an expert in this stuff, obviously, and he said that it is very easy to have good to twist the results in such a way that you have really good p-values, but you just didn't interpret the results properly. So we should be careful where EEG data is involved, and we see really good p-values. We should be on the lookout for methods how they've analyzed the data if it is mentioned, and think of ways that these could be twisted. It's not, I think it will not always be because of, this publisher perish culture that here is present in some countries, but also because um, I know I would do it. When you see such a good p-value, it's just like a rush, not the runner's high, but the scientist's high, the academic high. Um, and maybe that's part of the reason why they do it. Okay, just a second, and I will continue. Just give me a second. Oh no. Oh, I hope you can hear noise coming from my room. I tried to be as quiet as possible for the stream, the sake of the stream, obviously. And now I should be able to see. Nope. No. I can't see it. Channel. With Alright. Okay. Oh, hello there. I see someone has joined in. This is currently what I'm going through. It's a sort of a walkthrough with commentary of this paper called Vagus Nerve Stimulation Therapy for Treatment-Resistant PTSD. And it was basically a combination of this prolonged exposure therapy, which is the gold standard cognitive behavior therapy. It works very well with phobias, and short bursts of vagus nerve stimulation, which is achieved through an implant. And of course, the sample size is very small. It's like 9 people, and only 7 of those 9 people underwent the entire treatment. So they were until here. To do so, they developed the first inhuman miniaturized next generation implanted VNS system. Next generation, one of the most used marketing buzzwords. And using the system, they performed an open label early feasibility study. Open label basically means that oh shit. Well, wasn't their thing, I guess. That's okay. So, open label basically means that, as we said in previous streams, that both the examiner, both the researcher and the patient know that they're giving treatment. In all people receive treatment. There is no placebo control and other stuff. So okay. The treatment-resistant PTSD participants were implanted with the VNS device and underwent a 12-session course of prolonged exposure therapy with concurrent stimulation. And this is what it looks like compared to a penny. This is what it looks like. And they also have a app which controls it. So, in approximately 4 weeks after implantation, participants underwent the post-implantation baseline assessment, and participants then received 12 sessions of prolonged exposure therapy with VNS as detailed below. And following completion of the final session of PE, oops, no, that's a mistake. Okay, there was what I was talking about. 15 individuals met criteria and were enrolled. Of these, 9 participants underwent VNS device implantation and received treatment, and 7 completed all sessions of treatment. And yeah, the two participants that did not complete the full course of therapy received 6 and 11 sessions of PE before ceasing communication. And data for, the data that we're going to see is for the 9 participants that they used. Okay, let me just find the next thing. So participants were directed to perform homework exercises in accordance with standard PE practice. Homework sessions included listening to the session recording once per week, breathing practice, reading handouts, listening to the recorded imaginal exposure once per day, and completing in vivo exposure to other trauma reminders each day. Also, they performed something that I didn't know at all was existed, is 100% presence of essential PE components. So I assume the procedure was performed correctly, and 91% therapist competency, which is basically like a therapist competence assessment made by an independent reviewer, or sometimes multiple independent reviewers, and there are scores for in this therapist competency test or review. They look for two things, which are adherence to the procedure. So how to what degree is the therapist following the procedure for this treatment method, and second, how skilled they were, like if they provided the needed support, they knew when to provide support, how to provide support, in walking through patients with very vulnerable traumatic memories, because as all of the fellow people that have experienced trauma know, that this is a very, very vulnerable state that puts you in. That thinking about your even thinking about your trauma puts you in a vulnerable state, let alone exposure therapy. I can't imagine having exposure therapy with uh my type of trauma, but looks like it's effective, at least from this data. But one, the sample number is like, the sample is really small, but still, we're gonna get into the results a bit later. So all participants received stimulation at equivalent parameters, which is obviously it's crucial that everything was equivalent across all participants, consisting of 0.5 second strains of 0.8 milliamperes, 100 microseconds biphasic pulses at 30 Hz, delivered every 6 seconds during in-office therapy and homework sessions. So 0.5 second strains means that basically every 6 seconds, as you know, they received stimulation that lasted 0.5 seconds, and the amount of current was 0.8 milliamperes, which is, I looked at these parameters, I digged in, and it was said that these parameters are pretty standard for these kind of stimulation treatments trials. So biphasic pulses basically means that the current flows in both directions. It first moves out and then in reverse. 30 Hz, we all know frequency, and these biphasic pulses with the current flowing in both directions, not simultaneously, but first in one direction and then in the reverse direction. This is common practice that prevents tissue damage. Okay, so I'm gonna need just a second to figure this out. chat. Why can't I see chat? Okay, oh, finally. Okay. That person did not. That person that joined at one point just wasn't his thing. Oh no, why am I still on this tab? Oh no. I can't look at the chats. No. Okay, I'm gonna look on the Twitch chat. Alright. Sorry about that. Let's continue. So, now we're gonna go through the tests that they used. Pretty well tested, thoroughly tested, I mean, questionnaires. So, clinician administered PTSD scale for the DSM-5 criteria. This is the so-called gold standard metric of PTSD symptoms and severity. It's a semi-structured interview, which means it follows a rough structure, but there's also some improvisation involved in it. The PTSD checklist for DSM-5 which is a self-report measure. It's good to have both clinician administered and the self-report, just to reduce bias. And the post-traumatic cognitions inventory, which is a self-report questionnaire of trauma-related thoughts, again some self-report. And the hospital anxiety and depression scale, which is again a self-report, and because anxiety and depression tend to be comorbidities with PTSD. And we can, in here in table 2, we can see the adverse events or side effects. The most frequently occurring adverse events is incision pain, which happened to 2 people a total of 5 times, and the rest were just 1, which is pretty good. And as it's stated here, all adverse events were classified as mild and resolved spontaneously without treatment, which is great. So it is totally safe. It is not totally, but it supports the hypothesis that it is safe. So also the patient health questionnaire 9 is a short survey to evaluate severity of depressive symptoms. And the generalized anxiety disorder screener, a short questionnaire used to evaluate anxiety-related symptoms. So they have both a questionnaire that that evaluates both anxiety and depression, and they have separate questionnaires, one for anxiety and one for depression. And also they have the mini international neuropsychiatric interview, which is a structured clinical diagnostic interview to assess the major psychiatric disorders in the DSM-5. And psychometrics, which is mentioned here, psychometric studies show strong reliability and validity compared to other similar structured diagnostic interviews. So, time to get in the statistical analysis. Oh boy, my least favorite section of every paper, to be completely honest. It's just because I'm not that proficient in statistics yet. Okay, so I prepared like separate notes for this in order for me to be able to actually provide some even if a bit shallow of an overview of these statistical methods. So, okay, data were analyzed in a repeated measures ANOVA format, which basically means that they collected data from participants multiple times, and to analyze how their scores changed over time, they used this method called repeated measures ANOVA. And this method checks whether there are statistically significant differences in a person's results at different time points, which is what we need. So, continuous outcomes, as the CAPS-5 and PCL5, which is basically means the were analyzed using intent to treat mixed effects models or MEMS. So some of the data like test scores are continuous, which means they're numerical, and meaning they're numbers on a scale. Meaning they're numbers from scale. They use the model called mixed effects model, which includes fixed effects. They assign which are the fixed effects and which are the random effects. These are the two types of effects, and the fixed effects are those that are consistent across time, like the treatment. This is usually the independent variable is put as a fixed effect in these kind of models, and this includes random effects as well, which are differences between individuals, like each person's starting level. And they used intent to treat, which means they analyzed data from all participants, even if some missed follow-ups, which we saw that they did. Some did, and this keeps results more realistic and unbiased, is what is expected. Okay, so oh no, where did my dates go? Okay, yes. So while the dichotomous outcomes, for example, clinically significant anxiety and PTSD diagnosis, were analyzed using intent to treat generalized linear mixed models with logistic linking functions and a binomial distribution, which is other outcomes from these questionnaires are dichotomous. They only have two options, yes and no. For example, like, does this person have PTSD, yes or no? And for this, we use the model called a generalized linear mixed model, which works well for data that's not numerical, as is dichotomous. And logistic linking function helps the model deal with yes-no data, and binomial distribution matches the type of data, which is two outcomes. And this model also includes everyone, again the intent to treat, and accounted for both group trends and individual differences, which so far so good. Okay, all models used conservative, robust standard errors. So they used a careful method to estimate variability in the data that is less sensitive to unusual data points or small errors. And this makes the results more reliable, even if there are some odd or inconsistent data, which we have again from these two participants that we mentioned, that didn't receive sort of the full treatment, full course of treatment. So again, unlike traditional repeated measures, ANOVA mixed models do not assume sphericity or homogeneity of variance, assumptions which are rarely met. So traditional ANOVA, like as far as I understood, at least every statistical model has some assumptions. That's why when choosing a statistical method or model to analyze your data, you always need to be aware of the assumptions, and what assumptions you can go, what assumptions you just you just can't apply to your data. And so the traditional ANOVA, which is analysis of variance, assumes two things, which is sphericity, which is the relationship between time points is the same across all time comparisons, and homogeneity of variance is the amount of variability says that the amount of variability is the same across time. And as we as we know, in real life, these are almost never true, and mixed models don't need these assumptions, so they're more flexible and realistic, uh, which is so far so good. Mixed models are also intent to treat, while typical repeated ANOVA requires complete data. So if someone misses a follow-up, repeated ANOVA usually removes them from the analysis. Mixed models allow us to keep their other data, which makes the study more representative and avoids throwing away valuable information. No meaningful differences were observed between estimated means and raw values, which are presented like in the supplemental information. So I have the paper title here, so if you're interested in the supplemental materials, you can go ahead and check them out. Okay, so they compared basically the model's predicted averages to the actual averages from the data, and they were very close, which is great. And this means their model was accurate, and that the real numbers in a table, I think the real numbers are included in the table. So, just a second. I forgot where I was. Where was I? Not here. Okay. All raw data for all participants at each time point are represented in supplemental tables. As I said, mixed models, like the ones used here, require specification of the covariance metrics for the errors of the repeated measures. So these models assume certain patterns in how the errors are left over, which are leftover differences between predicted and actual scores, are related over time. So this pattern is stored in something called a covariance matrix, which describes how much two time points have moved together. Okay. Since misspecification of this covariance matrix can lead to incorrect results, we selected the covariance structure that best fit the data. So if they chose the wrong pattern, it could mislead the analysis, so they tested different options and chose the one that fits their data the best, which is what that means. Using the lowest KK information criterion and Bayesian information criterion, which is to decide which pattern or covariance structure fit best, they used these two numbers that measure how well a model fits the data, and lower values actually mean a better model. And the covariance matrices that were examined for each outcome were so they tried many different patterns, including unstructured, which has no assumptions, it is most flexible, AR1, which means closer time points are more similar, and toplets and compound symmetry and etc. These all make different assumptions about how the errors are related over time, and each one was tested for each outcome. So, oh my god, this is sadly going to be like hours long if I review every sentence, like every phrase. So I'm gonna stop here, and if there are any questions, I'll be happy to answer them about this analysis. You can follow through on like your own computer if you need, review at your own pace, and ask some questions, and we'll try to answer them together. Okay, so let's see finally the results. So the findings that they got to point to the safety of VNS therapy for PTSD, and the system delivered over 160,000 stimulation trays, and no device complications or performance issues were observed, which is absolutely great. This is awesome. Just a second, okay. Still, unsurprisingly, nobody's watching, but that's okay. So no performance issues either, because personally, if I got like an implanted device, I would really worry about it just short circuiting in my brain, uh, or just getting damaged and it's lodged in there. Um, I personally would be afraid of that. Okay, so let's see these graphs in like their full glory. Whoops. So what these mean, actually they indicate the p-values. So 2 stars indicates lower than 0.01, which is great. The 3 stars indicates less than 0.001, which is even better. So these are what they mean. As we can see, there is a very steep decline after therapy, which persists even though in um, smaller variants throughout the uh, later follow-ups, which can be seen with percent with PTSD diagnosis. Again, very steep decline after therapy, right after therapy, and oops, come on, okay, and improvement in CAPS 5 can also does the same thing, even though here the airbag. Oh, I forgot to mention the thick lines are the overall trend, and these thinner lines are the individual people. I'm really sorry for that guy or that girl, which is this. There is at least some improvement, but poor person here, right here. Still, the overall group trend looks great with very good p-values, and again, we observe the exact same thing here. Okay, so let's see how they described it. Okay, so as we saw, enduring improvements in CAPS 5 were observed 1, 3, and 6 months after the conclusion of this vagus nerve stimulation therapy, indicative of lasting benefits. Of the 7 individuals that completed therapy, all showed the loss of PTSD diagnosis enduring 6 months after the completion of therapy, and at each follow-up, p-value was less than 0.001 compared to baseline. Additionally, all categories of the CAPS 5 subscores demonstrated comparable substantive reductions, suggesting that improvements are not restricted to a single construct, which is again, this gets just better and better. So initial severity is not predictive of response to VNS therapy, which is again great, can be used by people with various stages, or with people both with better or worse cases, which is great. This therapy also improved the PCL5 scores at each time point after completion of treatment, and again, really good p-value. HADS-A, or the measure of anxiety, also demonstrated significant improvements at each time point, and the PTCI and PHQ-9 scores exhibited similar cumulative and lasting improvements over the course of treatment, with significant benefits observed at each assessment time point after the cessation of therapy. So they do not observe correlations between post-treatment CAPS 5 score and homework completion, which also suggests that increased adherence cannot itself explain the benefits of VNS therapy, and clinical metrics were stable after implantation, indicating that implantation and presence of the device without delivery of VNS does not produce benefit through a placebo effect. So, about the discussion, so here they report the results from an open-label early feasibility study examining the use of VNS therapy for treatment-resistant PTSD. They find that VNS therapy is safe and feasible to implement in individuals with PTSD, and additionally they observed substantive, clinically meaningful, long-lasting improvements in multiple metrics of PTSD severity. So, also, however, given the open-label nature of the study and small sample sizes I mentioned like multiple times, this finding called for confirmation in a randomized control trial. So the mechanisms of this, we're getting now acetylcholine and norepinephrine, which are released in response to vagus nerve stimulation and mediate many synaptic and ultimately behavioral effects of paired VNS, are critical to extinction learning. Plasticity in fear networks has been directly observed with VNS therapy in preclinical models. So pairing VNS with fear extinction training drives robust plasticity in connectivity between the basolateral amygdala and medial prefrontal cortex. This reorganization of connectivity is supported by biochemical changes in synaptic architecture, including increased GOUN2B expression and KII phosphorylation and reduced expression of ARC. Okay, also some biochemical changes. Nice. Now we see the different questionnaires and how they improved over the sessions of this exposure therapy. As you can see, results are great. And here I think they put outliers whose results remain basically almost the same till the end, sadly. But I assume they took with the overall trend, which is of course there may be like a small sample of people for which this treatment won't work, but I think that's the case for many treatments. Okay, so a matched amount of VNS delivered in offset by tenths of seconds from the condition Q does not result in enhanced fear extinction. So this has to be extremely precise. And VNS therapy relies on psychotherapy to guide adaptive changes in circuits associated with fear processing and enhances these effects by engaging neuromodulatory networks. And also, a congruent approach using paired VNS coupled with upper limb rehabilitation therapy recently became the first FDA-approved therapy for chronic stroke, highlighting the clinical potential of this approach, which is awesome. It's also, as far as I read, it's also used in depression and in epilepsy, for depression and epilepsy. So one potentially significant hurdle in the clinical implementation of VNS therapy is the requirement for an implanted medical device. Although some non-invasive modalities that seek to activate the vagus nerve have been explored, studies examining fear learning and extinction that employ these approaches observed, sadly, small or mixed effects, which is very unsatisfactory, obviously. And as with other implanted devices, they note that VNS therapy does not constitute a first-line treatment approach, or rather, as reflected in the demographics of this study, VNS therapy represents a potential intervention in the context of chronic, moderate to severe PTSD that does not respond to less invasive conventional first-line treatments. So this is basically more like a last resort, never the first thing to turn to, obviously, and yeah, that's what I said about VNS therapy. It has been FDA approved for major depressive disorder since 2005, and thousands of individuals have undergone implantation of a conventional VNS system for major depressive disorder. And although the functional outcomes used in the study have been extensively validated as gold standard measures, they are comprised mostly of self and clinician-administered surveys, which are open to bias, obviously. Additionally, the prolonged exposure therapy itself is known to be effective in some individuals. And although the majority of participants had received prior cognitive behavioral therapy, it cannot be conclusively told cannot exclusively ascribe benefits to the addition of the vagus nerve stimulation. So the compelling improvements observed in the EFS should be evaluated in a more rigorous double-blinded placebo-controlled crossover study design that directly compares active and sham stimulation with uh, prolonged exposure therapy. So with that, these are some chat questions and polls. Would you consider VNS therapy for treatment-resistant PTSD? And how do you think VNS therapy compares to other neuromodulation techniques like TMS or TDCS in treating PTSD? But since there is nobody currently watching, I'm going to conclude this stream, and let me know what you think if anybody sees this. And for now, I'm out.